Cesar Netto is joining us from the University of Iowa. Thank you for being here and being a part of this. Cesar, is a colleague and has become a good friend. He's originally from Sao Paulo, Brazil, where he took care of the Brazilian soccer club for a long time, and then decided to transition to the U.S. primarily because of his strong interest in research. And so he's now at the University of Iowa, where he is a assistant professor and director of the Orthopedic Functional Imaging Research Laboratory. So he was kind enough to agree to join us to talk about what he's learned about weight-bearing CT scan. He's the preeminent expert in the world on use of weight-bearing CT for foot and ankle, particularly to assess and address deformity. And he's also widely published on this. His group has been a major presence in our journals and at our meetings. So Cesar, thank you for being with us and sharing some of what you've learned about weight-bearing CT scans, and I'll let you take it away.
Oh, thank you, Dr. Hunt, for the invitation. It's a great pleasure to be here. Thanks for the kind words. And I'll try to share. And this is I don't know how long we have, so what is the timing? But you guys can stop anytime. I'm just trying to go through.
Yeah, Cesar, usually it's just 30 to 40 minutes of presentation and then Q&A. If you go a little shorter, a little longer, that's totally fine. But it's an hour-long conference, so we just would need to plan to wrap it up in 55 minutes.
Good, excellent. Well, I'll go through some here and we can stop. First, I'm going to be talking about 3 specific diagnoses here, but we're going to be talking about weight-bearing CT in foot and ankle. I do have conflicts with this, so I want to make sure that you guys understand that. I always talk that even though I do have financial conflicts, I think the most important conflict is my passion for the technology. So there's always a lot of passion involved with what I talk about the weight-bearing CT. I don't have pictures with you, Dr. Hunt. We have to take one next time. Maybe I'll do a print screen here so I can put in my talks. But I did have the pleasure to spend time with Shuyan and Dr. Myers. I'm not sure if they're here or not, but wanted to put there. And I always want to thank my co-workers here in the lab. Kevin Deeburn is the Ph.D. that co-runs the lab with me, and we have some international fellows. Nassimi and Kepler are currently working with us, and without those guys, nothing would happen. So, especially for the residents, I think it's important for us to talk about what is weight-bearing CT and why it has been changing foot and ankle. We are all used to use conventional radiographs. We know the limitations. We have to understand it's kind of a unidimensional or bidimensional. In the best scenario, if you have 2 views of a 3-dimensional structure, that is the foot, and there's nothing more complicated than the foot in orthopedics. Of course, we bias opinion again, but we know that these create biases in assessment of 3-dimensional deformities, and it's an intrinsic limitation of conventional radiographs. And this has been shown in the literature. As you change positioning of the foot, as you rotate the ankle, in this case, you're measuring tibial-calcaneal alignment here. As you rotate the foot, the alignment of the same patient changes related to the bias of the positioning. So this is we know. And then we go for 3D imaging, where CT, traditional CT, that is a non-weight bearing, that for foot and ankle is always bad, especially in the scenario of deformities. So you could have a good CT scan, regular CT scan, for example, for fractures that I think you guys, interarticular fractures, that we do that for assessing position of fragments and planning surgery and things like that. But we're competing with the other specialties. There's a ton of radiation that we're going to talk about. And it's a much easier schedule to fit patients into it, in a daily basis or on an emergency basis. Why this is so complicated? This is an X-ray that can show up in any test for residents, right? So if we ask any question about this X-ray for residents, the next step you have to say is give me a weight-bearing CT radiograph, right? Because for foot and ankle, if it's non-weight-bearing, unless you're talking about a fracture, it's not enough. So you would have to ask for weight-bearing X-rays, and even weight-bearing X-rays. And we know that the bone, like I said, the foot is very complicated with 28 bones and 33 joints. This is the same patient pretending to put weight. You see it saying here weight bearing, but this is the x-ray when you really tell the patient to put weight because he was trying to preserve it to avoid pain. So you can see the amount of collapse that this foot has. And this is the x-ray of the same person without really putting weight. So it depends on the examiner to tell the patient to really allow the weight to go through. And that would be the same for weight-bearing CTs. And people try to do combine, right, the CT scan or the 3D imaging with weight-bearing using conventional CT to do simulated weight-bearing. These are just two images of the literature showing like kind of compressive weight load, compressing the foot against a platform. That does look like some medieval tables, so kind of a little bit scary. But a lot of the literature in the, I would say, late 90s and early 2000s came with the simulated weight bearing, and actually very good studies that we're going to reference some of them here. And then cone beam CT came with a different technology. It's not the same as conventional MDCT. It's a cone beam, like the name says. So you have to do a single rotation around an object, and you create a sinogram, and that the detector will be able to get out of this conical beam in one single pass. It will be able to get a true 3D image, right? And it's quick. It comes with advantages of being quick, but also has a disadvantage of being quick and having lower radiation. That is, as you guys are going to see here, initially, the quality of the images, especially if you're talking about bone quality and bone trabeculi, was not super good. But it is, you can do true natural standing position. It's fast, like I mentioned, and very low radiation dose. And that's one of the most important things that we have to understand and we have to tell patients. And it was one of the blocks or the limits for the use of the technology. It's relatively small, so you can, this is one that only scan the foot and the ankle, and it can fit into small facilities and private clinics as well. And it allows, like you say here, it allows you to have, if you want to have x-rays, you can still have what is called digitally reconstructed radiographs or DRRs, that if you want to still use 2D image, you can still do it. And this is just one, there are several references for this, but if you compare a unilateral conventional CT of the foot versus a bilateral cone beam CT, it's 22 times less radiation. So you have to do 22 bilateral cone beam CTs of the foot and ankle to get the same radiation of one unilateral conventional CT. So it's way less radiation than a conventional CT. Then new equipments where, of course, there's a need to go up, right? So we can look into the whole lower extremity. So this was the one that goes up to the knee. So you could have images like this, where you get the knee and the foot and ankle. You can get from knee down, and that was very important for planning total ankle replacements or protocols of pre-op planning. The most recent one is the one that goes up to the hip, and this is just one of the versions in the market. You can also do superior extremity if you want, as we can show here in the image there on the bottom right. And this is just, this was the early image where the hip was not 100% good in this video. So we participated on the improvement process of this machine here. And initially the hip, because it's much deeper, the cone beam has difficulties to get to the hip. But you can see here how now the images are much better. This is kind of a thicker cut in the coronal plane. This is also to show the bone trabecula, like I told you guys. Initially, the image was not super good for you to see the trabecula, and this is the current version of the software and also the hardware, because usually there's updates in the hardware and in the software. But you can see the trabecula pretty well. And there's also a lot of work on metal artifact reduction. So you can see here without the metal artifact reduction and with the metal artifact reduction, so you can get pretty good assessment between bone metal interfaces, like you can see here. So I think there's a lot of improvements in the technique. There's a promise in the market that soon there will be a new hardware in the market that will allow the spine to be imaged as well. So you would have low spine, pelvis, and the whole lower extremity in the same image. So it is going up. At some point, potentially there will be a full body if needed. Like I said, you can have this digitally reconstructed radiographs. So these are radiographs out of the weight-bearing CT or the cone beam CT images. It doesn't look exactly like a regular conventional X-ray, but for triage, just for you to see overall alignment, quick assessment in clinic, it's pretty good. And you can spend more time looking into the 3D images if you want later. And the most important thing for people to understand, and I'm talking not just about patients and providers, but also insurance companies, is that the indications for weight-bearing CT or cone beam CT are completely different from the indication that foot and ankle surgeons would use for conventional CT before. So why would you do a conventional CT? We talked about one indication that would be like intra-articular fractures, maybe to assess bone healing, maybe to assess fusion healing, excuse me. The indication for cone beam CT now is to replace X-ray. It's to get 3D image right away from a 3D structure, very complex 3D structure that is the foot and the ankle, rather than going into conventional radiographs. So the indication, this is very important. And when I got here in Iowa, people would just say, who is this crazy guy that's just doing CT scan of every single patient? And I had a lot of problems with insurances. And now I think they gave up. So we had like tons of peer-to-peers before. And now I think they see my name there and they say, well, that's the crazy guy. He's going to do it anyway. So just let it go. So maybe, Dr. Hunt, do you want me to stop here and then maybe talk about this before we go into the specifics, or you want me to keep going? I don't know exactly what is the format they usually do.
Yeah, that's perfect. I had a couple of questions. So you bring up a really good point, and that is the challenges surrounding getting these paid for. Now, our foot and ankle center is a hospital and facility, which I assume University of Iowa is. So there's a pretty big markup on all imaging relative to what it would cost at a private clinic. So for that reason, like the charge for a weight-bearing CT is somewhere in the neighborhood of $3,500. So that, we have to get it pre-approved, which makes it difficult to do it as like our initial screening tool for a patient that comes in with a flatfoot deformity or arthritis. So we have to have them come back and get the scan at a later time, which creates some logistical difficulties as well as the added expense. So my question is, do you feel like you've overcome that? And do you think that is why this technology has not exploded? Because, really, as you've already said, this should supplant plain radiographs altogether. Like, we should be getting weight-bearing CTs instead of X-rays for pretty much everybody in the foot and ankle clinic, but we can't because of those two issues. So, the comments.
Yeah, well, you're right. I think I've been winning the war here in Iowa, but I think it's about everything that is new takes time for people to accept. I think the insurances, the mistake was that the coding for this went exactly as the same coding as regular CT scan. So I think that was a mistake from the beginning. I think the companies that were selling the machine should have advised people to use different codes. And I know there's a problem with radiology as well, because radiology, I'm not sure if we have a radiologist online here. I'm happy to get inputs from them. But when we get 3D imaging, they feel obligated legally to look into the whole 3D. So maybe you could miss a small tumor, or you could miss a stress fracture, or something like that. It wasn't the primary indication for the CT scan. So that there's a five-way radiology as well, because they want to charge more money because they are spending more time to assess those tests compared to a conventional X-ray. But I think, and trying to answer your question, is the more people start indicating it, and the more the companies understand, not just the companies, but patients and medical facilities as well, they understand that this is is here to replace conventional X-ray. I think we're going to find a midpoint with the price where it's not going to be as expensive as a regular CT, not as cheap as an X-ray, but there will be a different chart where radiology can run through it quickly just to rule out some bad stuff and provide you conventional radiograph reports rather than a full three-dimensional report. But it's a tough fight, but I think if we don't do it, if we don't push, it's never going to happen.
Yeah, I think you're right, and I don't want to get too deep into the weeds on that, but do you feel like you've established that best practice at your institution?
Yeah, I mean, every single new patient that comes to see me gets a weight-bearing CT, and because I'm usually seeing patients that were referred. So the way we found that we could kind of bypass was if they had a foot X-ray done anywhere before with any other medical provider, we can say that we already have conventional images that we need three-dimensionally. That's the way we have been doing to try to get patients to do the weight-bearing CT same day that they're seeing me, but they do the CT scan before they come to see me, and then I already have the images. But occasionally I have to order after. But that's what my PA has been doing, is looking into X-rays, putting like a quick note, and then saying we need 3D images. So that's the way we're doing before we see them.
Got it. Helpful. Any other questions from the group at this point? All right. See, this is great. Keep rolling.
Yeah, and then people always ask me, and again, this is a very biased opinion for me because of my passion mostly, but what will be the role of weight-bearing CT in foot and ankle surgery? It's changing the practice. It already changed for some diagnoses, but I think it will change for most of our diagnoses, the three-dimensional deformity. And where do we stand with the data, right? Because we have to base this in data, and I think this is one of the most special parts of weight-bearing CT, because I think we have pretty strong data in some specific diagnoses that we're going to talk here. But right now, we're still validating old 2D concepts or assessments in the 3D environment. But like I mentioned, there's already very good quality data for some pathologies. I like to tell the residents that for you, we have a lot of concepts. They're not wrong. They're great concepts, but they were based on two-dimensional assessment of problems. So I really think that sometimes with the weight-bearing CT and bringing 3D to your daily assessment, sometimes you have to think outside of the box, and you have to unlearn some old concepts. You have to let it go and then rethink that same concept in a new scenario. So you have to be open to new concepts, or to let old concepts go so you can understand what you're seeing. And this is going like crazy. So these I checked this yesterday. So very short assessment on PubMed with weight-bearing CT in foot and ankle, and we have weight-bearing CT images, not just in foot and ankle, as I'm going to point here, but 176 results in PubMed, and if you see there, it's really growing exponentially, and I think it's going to grow much more. And the reason is, if you look, the last 2 publications on PubMed, they're from knee surgeons, right? So this is going to be, like it was for foot and ankle, it's going to be a blast of sports medicine and joint replacement surgeons, because they just found out, they just started using this, and I think they're going to have a lot of new data coming out. So like the last 2 are knees, and we haven't talked about the trauma teams as well, because I think this will be a huge thing in ER facilities, because you can get like a wrist CT scan in 20 seconds. So you don't have to do all those crazy positions of the wrist as well. So I think in the trauma setting, having a cone beam CT would save a lot of time and a lot of money as well. But that's not my specific talk here. And then the number one diagnosis, and that I think weight-bearing CT already changed the game, is flatfoot or progressive collapsing foot deformity. That is the new proposed terminology that we're going to see. So last time I checked, 57 results for weight-bearing CT and flatfoot deformity. And go into the details here. If you want to be very, if you ask me directly, tell me very quickly, what is the real deal for weight-bearing CT in flatfoot deformity? It is the coronal plane assessment. Of course, it's much more than that, but it unlocked the assessment of the coronal plane. You can see here the same patient X-ray and weight-bearing CT, where you can't really tell what's going on the lateral side here. And with the weight-bearing CT, you can clearly see the impingement, the subfibular impingement between the calcaneus and the distal fibula here. So if you were asked what is the most important part of a 3D imaging, weight-bearing 3D imaging foot and ankle, that's the coronal plane for sure. And this is not new. I always like to reference this study. This is 1999 JBJS from Seattle. Dr. St. George is the senior author here. And he showed that comparing in a very clever way of doing things and with simulated weight bearing, he was able to show rebuilding the surface of the articular facets of the subtalar joint. So here you can see the posterior facet, here you can see the combined middle and anterior facet. And when you compared controls in flatfoot patients, there was a regular normal overlap between the facets in the controls and a significant amount of subluxation of both the posterior facet and the anterior and middle facet in flatfoot patients. And those were significant. He didn't compare the two, anterior, middle versus posterior facet, but you could see here by the image that the subluxation of the anterior and middle facet is more significant than the subluxation of the posterior facet. The same group also introduced two very important concepts here. So we talked about the first one, that is subluxation of the subtalar joint, and the terminology that was introduced there, that is peritalar subluxation. And I love that. So flat foot is not just a collapse of the arch. It's much more complicated than that. It's a three-dimensional collapse of the foot. And in the hind foot is subluxing out underneath the talus. So the whole foot is dislocating under the talus. And so that's why I love this peritalar subluxation terminology. So they also introduced the terms of a sinus tarsi impingement. That is an extra-articular impingement. As the foot rotates externally and everts under the talus, you start hitting the lateral process of the talus into the G-send aspect of the calcaneus. And 92% of the flat foot patients had it, 0% of the controls. And subfibular impingement that I just showed in a different image there, where the calcaneus is hitting the fibula, where they show that 66% of the flat foot patients had that and only 5% of the controls. For me, most importantly, they show that every single patient that had subfibular impingement also had sinus tarsi impingement, but the opposite was not true, giving an idea that probably sinus tarsi impingement comes first and subfibular impingement is a later finding of more deformity. Then the group from HSS also provided a lot of very interesting data for flatfoot. One of them that I think one of the game changers is this paper here from Foot and Ankle International 2016. Lee Cody is the first author, Dr. Ellis is the senior author, where they came with a new angulation that was, they named it superior talar, inferior talar angulation. So you see there's a line on the talar dome, a line on the posterior facet of the subtalar joint, and this is the 50% or the midpoint of the AP length of the subtalar joint, the posterior facet. And this is an intrinsic angulation of your subtalar joint. So it's referencing two lines inside the same bone. So it's kind of like at the end of the development of the foot, that's the angulation of your subtalar joint. So they show that if you have a more angulated or a more valgus inclined posterior facet of more than 17 degrees, that magic number would divide flat feet and control patients. So in other words, there might be an intrinsic malpositioning of a subtalar joint in valgus that will allow the foot to collapse more. So you would be born, or at the end of your growth, you would have a propensity to have a flat foot deformity. And I think this is a very important study. With those concepts in mind, in 2019, I published these at JBJS with the HSS guys, where I started looking more details, as Dr. St. George showed before, that control patients had a very well-positioned middle facet of the subtalar joint, as you can see here and here, and the flat feet or progressive collapsing foot deformity patient had a very subluxed or almost pretty much dislocated middle facet of the subtalar joint. And even though that was shown before, that was forgotten in the literature. After Dr. St. George showed those two, the posterior and the middle facet and anterior facet all together, nobody ever paid attention to the middle facet anymore. And what we showed was that the average subluxation of the medial facet in flatfoot patient was 45% versus 5% in controls. And if you had an uncoverage of more than 18%, that was pretty much diagnostic of symptomatic flatfoot deformity, or what we would say now, symptomatic progressive collapsing foot deformity. And I think that's it's an important finding that I think will guide next steps in the treatment of this. Another paper that I want to see, so we're going to the 3D, so we have to talk about 3D. So Dr. Francois Lintz is a great friend from France. He published not in flatfoot deformity, but what is called foot and ankle set. And I think it's important that you guys understand that. Hopefully, Dr. Hunt and your group will be using this. And I know the Shuyan and Dr. Myers are doing some work on this. But what you do here, instead of talking of valgus and varus, right, you will look into where is the foot tripod position, where is the ankle position, and you're going to say it's an offset, as the name says. So is your tripod under your ankle? Is your tripod medial to your ankle? Is your tripod lateral to your ankle? So you harvest 3D coordinates of the tripod. That will be the weight-bearing part of the first metatarsal head, the weight-bearing point of the fifth metatarsal head, the weight-bearing point of the calcaneal tuberosity, and then you find the center of the ankle joint, and the software will give you the 3D position. So this is XYZ planes of metatarsal 5, XYZ planes of calcaneus, and XYZ plane of the center of the talus of the talar dome. And this is the tripod. This is where a biomechanically perfect aligned bisecting line would be in the tripod, that's F, and T is where the center of the ankle is. So in this patient, the center of the ankle is out of the tripod, is medially positioned. So in other words, the foot tripod is laterally positioned to the center of the ankle. So that would be valgus, if you want to still use valgus varus. But I think it's a much more elegant way to say is that the foot is positioned laterally to the center of the ankle joint. And I use this routinely for my patients. Dr. Lintz published that in a normal population, the alignment would be the foot and ankle set is a mathematical calculation between where the center of the ankle is and where the center of the ankle should be. And it's given in a percentage because it's divided by the length of the foot. So if you have up to 5.2, that positive is valgus, negative is varus. So minus 0.6, so minus slightly varus to 5.2% of valgus is considered normal. So we validated these for flat foot deformity, where we did several measurements, traditional measurement for flat foot, measuring collapse of the longitudinal arch, hindfoot valgus alignment, forefoot abduction, and subtalar joint alignment, like we talked about the peritalar subluxation. And we did foot and ankle offset. And we found that when you measure foot and ankle offset, you're measuring all this together. The correlation was very strong between foot and ankle offset and these four measurements here. That would be talus first metatarsal angle, hindfoot moment arm, talonavicular coverage angle, and subtalar horizontal angle. So when you do foot and ankle offset, you're measuring four planes or four measurements, 3 planes in a single measurement. So you wouldn't have to do several measurements. If you're assessing a progressive collapsing foot deformity, you do foot and ankle offset, and you have a pretty good measurement that will estimate all the other ones without the need of doing manual measurements. And I want to highlight these again, just to synthesize, because especially for the residents, these are new concepts that can actually, as one resident asked me, these has been in the literature since 1999, and it's JBJS. So these could show up, these concepts can show up in residency tests. And so you guys should know. So we talked about malalignment in valgus of the subtalar joint. We talked about subfibular impingement. We talked about sinus tarsal impingement, and we talked about subluxation of the subtalar joint, either in the posterior facet that we can see the uncoverage here in red, or the medial facet where we can see the uncoverage between those two lines here. So these concepts are changing the treatment of flat foot. And I think they can already show up in tests because it's in the literature since 1999. We're just giving more focus or more, we're highlighting this better now, but it's already out there for a while. And this is so important that when we had the consensus that Dr. Myerson was part, and we recommended a new terminology for the problem. So it's okay for you to have a flat foot. The problem is having a flat foot that is collapsing. So those are the ones we have to identify. So the progressive collapsing foot deformity would be a foot that is collapsing, that could be flat before. So you can be born with a flat foot, but at some point in your life, it will start collapse, or maybe it won't. That's the key question, is to how can we predict the ones that will collapse? But this concept that I just showed you guys was introduced into the new classification system that we proposed. You can see here that's class D is peritalar subluxation, and sinus tarsus impingement, subfibular impingement, subtalar joint subluxation were introduced, and I do think that these will guide treatment in the next several years for flat foot. We recently published, as I mentioned to you guys, the assessment of the medial facet and the foot and ankle offset together were the most diagnostic accurate tools to separate flat foot and or progressive collapsing foot deformity and control. So if you see here the sensitivity of the medial facet subluxation, it's 100%, specificity of 92%, and you see how the foot and ankle offset as well is very high, 90%, almost 90%, and 100% specificity. So combination of two measurements pretty much tell you with threshold values. You can see here that was 28.7% subluxation of the medial facet and 4.6% foot and ankle offset together give you pretty much, in other words, if you have a patient with a flat foot that has a subluxation of the medial facet of more than 28 and a foot and ankle offset of more than 4.6, this is a very red flag. It's a red flag that you should follow this patient very carefully, because this patient is in collapse. And if you're not recommending surgery now, you should at least see the patient back in 3 to 6 months to see if things are getting worse or not. Dr. Hunt, I can go on and on here in the flat foot, but maybe we should stop, because I know these are new concepts, and I don't want to overwhelm the residents. So maybe we stop here and talk a little bit more about it before I keep going.
Yeah, I think that'd be reasonable. This is really interesting stuff. So what do you think, how would you say that this has changed your approach clinically, Cesar? Obviously, you're able to see and measure, displacements in the coronal plane. You get a better understanding of, where joints are arthritic. How have you seen this change your clinical approach? Like, are you more likely to intervene earlier or intervene differently based on your weight-bearing CT scan experience?
Yeah, 100%. I really use this data to tell patients. So the first time I see them, we'll get the weight-bearing CT, we look into the images, and if they have the red flags, like we just discussed, if they have a significantly inclined posterior facet, okay, more than 17 degrees, like the HSS paper showed. If they already have sinus tarsus impingement, that would be this. This is not arthritis. This is sinus tarsus impingement. This is extra-articular. It's in front of the posterior facet. If they have sinus tarsus impingement, I do tell them that this is a footing collapse. There's a high chance that this will keep going. And even though we cannot prove, I do think that those are the signs that are telling you that if you don't do something now, if you don't recommend surgery to reconstruct this or to improve the alignment, the subtalar joint will start to degenerate. So these patients will go into subtalar joint arthritis. They will go into tendinonavicular and calcaneal-cuboid joint arthritis. They might, the ankle might get involved, especially if you have subfibular impingement. So I tell them that you have red flags for these progressive collapsing foot deformity. If we don't intervene, of course, considering they already are symptomatic more than 3-6 months, they tried conservative treatment. If we don't think about intervening now, these might degenerate in the next 5 to 10 years. And the next time we revisit this, we might have to do a fusion. So I try to avoid hindfoot fusions as much as I can. And I think it's not as benign as we think it is. If you have to fuse one joint, you should fuse your subtalar joint. You should spare your tendinonavicular joint for sure. But I try to push the limits for flat foot reconstruction. And I tell them, I give them the data, and I usually follow them up for 3 to 6 months. If the pain is still there, and if the deformity is getting worse, I offer surgery. I don't force them, of course, to do the surgery, but I think it's important that they understand it's not as benign as just say, this is a flat foot, just let it go. You have this for your whole life, and maybe we shouldn't do anything.
Yeah, no, that's really interesting. And then you mentioned that because you'll see these, the peritalar subluxation, you'll see the shifts on the coronal plane. You're more likely to say, hey, we need to keep an eye on this. So presumably you're getting follow-up weight-bearing CTs. So do you have like some series where you're identifying factors associated with collapse that might help you better predict this in the future?
Yes. Well, this is a very important question that hasn't been answered yet. So we have been following patients longitudinally for conservative treatment as well, and patients that refuse any surgery. So I've been here for 3 years, just completing 3 years now in June. So data is going. We have some prospective data going on. We haven't assessed that yet, but it is an idea. The other thing that is important that we're starting now is there's not a single cohort of asymptomatic flat feet, right? People that have flat feet and have no symptoms. So we are signing up patients now in an IRB approved study. So we're advertising for people that think they have a flat foot to come to see us for a weight-bearing CTE, because it would be important for us to understand a majority of the case control studies are comparing normal feet versus progressive symptomatic flat foot. We need a comparison between asymptomatic flat foot and symptomatic flat foot to show why some people hurt and have symptoms that need treatment, and why some people have flat feet and never have pain in the foot. So this is another area where we're working on, is that I think it would be very important, to be honest. I think it's gonna, if I could hunch guess, I think that the amount of peritalar subluxation in asymptomatic flat foot will be significantly decreased compared to the symptomatic ones.
Yeah, I would think that. Are you getting weight-bearing CTs for your bunions, like for
Yes.
your bunions? So that's
100%.
probably So you may have a lot of data now, because a lot of those patients have asymptomatic pes plana valgus. So you may have some good data already.
Yeah, that's true. That's true. Unfortunately, we're not going to be able to get there, but I do have a recent publication with. I'm going to run through this because there's not going to be time to go through all this. I want to show the 3D stuff. But yes, we just published a cohort where we compared with more focus on Alex valgus in the rotation of the medial column, comparing Alex valgus with no CT measurement that would fulfill a diagnosis of flat foot versus Alex valgus with measurements that would fulfill diagnosis for flat foot. And we show pretty interesting differences in the amount of rotation and collapse of the medial column. I'm happy to share with you guys the publication, because I don't think we're going to get there. But anyway, we're bringing this asymptomatic flat feet from the community, right? Patients that we're actually showing the fingometer. Like, if you cannot put your index finger under your arch, you probably have a flat foot, and we would be interested in seeing you. But I think that would be very exciting, very important data, actually. So we're very excited about that next step. Can I continue here, Dr. Hunt?
Yeah, perfect. Thank you.
Yeah. So, and then we wanted to bring this to a real 3D level, right? So we started playing around with something that's called distance mapping, where you segment the bones and you calculate millions of points between two structures. We're showing here the distance maps in an ankle joint, as you can see here. Why? What we did before was just looking into one single coronal plane cut and trying to predict subtalar joint subluxation. But we wanted to do similar to what Dr. Sanjorjan did back in 1999, but with a much more robust technology now. So this is the distance map. So here, what we see blue is normal joint interaction. So you can see the normal joint interaction in a control in the posterior facet, in the medial facet, in the anterior facet. What you see in gray, dark gray here, is just a shadow of the talus that is far away on the top of this. And when you look in the PCFD, you can see now that there's a lot of areas in the posterior facet where there's no normal interaction between the joints, so probably subluxated. You can see this red part. Red means fire, means that the bones are too close to each other. So you can see some close proximity between the talus and the calcaneus here. That is the sinus tarsus impingement, but in a much more visual way. You can see that the posterior facet is pretty much without distance map, so there's no blue there because there's no opposing articular surface, and the same in the anterior facet. So this is a 3D assessment of what we just showed, and we converted that into just playing with the colors here. So now we told the software, if there's more than 5 millimeter distance between the bones, and then you show me in purple, in pink. So you can see here the sublux area of the posterior facet. You can see that the middle facet is completely sublux. You can see the normal interaction in dark blue. And in the sinus tarsi, there should be no interaction between bones. It should be gray. And you can see how the coverage of the sinus tarsi is increased significantly. So we show that comparing progressive collapsing foot deformity patients and controls, there's an average decrease in the coverage of the middle facet of approximately 47%, and increase in the sinus tarsi coverage of up to 286%. So you're giving much more accurate numbers to, and this is a real 3D assessment rather than a single cut assessment that we did in the JBJS paper, as I showed you guys. So this is much more accurate and much more complete than a single cut. And we're doing that the same for the ankle joint. I'm not going to go into the details. And we're also doing the same for the Chopard joint. We're combining all this data and we're showing with much more accuracy and much more complete assessment three-dimensionally what's going on with all the joints as your foot progressively collapses. And this is a cool video where you can see a normal foot going into a progressive collapsing foot deformity, and you can see what happened with the distance maps and the coverage maps. So you can see how the middle facet goes from normal interaction to a dislocated, and you can see how the sinus tarsi gets covered, gets impinged by the deformity, because the calcaneus is externally rotating under the talus, and the lateral process of the talus feels the G-sane aspect of the calcaneus. And the idea that I want to do this is to be able to give numbers to patients. So this is my patient, one patient of mine, where I showed the patient so she had 47% coverage of the sinus tarsi before surgery, 65% coverage of the middle facet before the surgery. After surgery, we were able to decrease the sinus tarsi coverage for 10% and increase the coverage of the middle facet to 88%. So we still have to correlate this with outcomes, right? How important this is and how this improve outcomes. That's what we're doing now in a prospective cohort. But ideally, you can give numbers. You cannot just tell patients, oh, you got better. No, you can give them precision of how much better you were able to do. So this is the same video of a patient of mine before surgery and after surgery. I want you guys to see how the talus is derotating back into position without a fusion, right? This is just medial displacement calcaneal osteotomy and some first-rate procedure that I think here probably was a cotton. So you can see the foot or the peritalar subluxation being corrected. You can see the whole talus rotating back into position when you compare pre-op and post-op. And I think this is pretty cool. And I think it will change treatment of progressive collapsing foot deformity. We're playing with some other stuff as well. We're playing with stressing the foot dynamically with braces, seeing if conservative treatment can improve measurements. And as I told you guys, we have been doing this distance mapping. We're doing a cadaver study and playing around with how much displacement changes which measurement. So MDCO 5, 6, 7, 8, 9, 10 millimeters. What happens with the measurements? Same for cotton, same for lapidus, same for lateral column lengthening, and seeing what happened with each one of the measurements. And we're trying to feed the software with this information so we can potentially predict and plan surgery in a way that we know exactly. This is just showing the cadavers as you move your heel, what is going on. And you can see all this derotation that I showed before and in a real patient. And hopefully you can use a pre-op planning tool and you can predict exactly what is going to happen. How much do you have to displace your heel? How much do you have to lengthen your lateral column if you need to do that? how much you have to bring your first rate down, and what the correction will be. And this it's not possible without an artificial intelligence algorithm that you constantly feed what happened with patients, and we're using cadaver data here as well, but very excited about that as well. I'll stop here. This was the flat foot. I'm not sure we're going to have time for anything else, Dr. Hunt. I just want to mention that the two other diagnoses that weight-bearing CT has been contributing a lot is Alex valgus and syndesmotic injuries. I'm happy to share my full lecture with you guys if you want to look into that, but it's so much stuff that there's no way to cover all in a single lecture.
Yeah, no, I get. Well, that was terrific. And you know, to your point, you know, hallux valgus is another complex deformity that's hard to really assess with radiographs alone. So I think that's a place where weight-bearing CT scan shows a lot of promise. I'm curious about, and then I'll open it up to the group. I'm curious about what you just mentioned, Cesar, that that the concept of you know, sort of a planning program that's based on real data from patients, meaning what the impact of a certain calcaneal position would be, and therefore what happens as you correct it, so that you can so there's a little less guesswork in the angle that we choose or the correction that we choose. How can you maybe comment, how far along are you on that? Is that conceptual now, or are you close to where that will be a commercially available program?
Yeah, well, it is complicated, right? So many variables, and patients are different, deformities are different. I think we started this as soon as I got here in Iowa. We were working with a company that you know for sure, and that's called Desior Analytics. That it's a software company. It's a Finnish software company. So we have been working pretty closely with Desior for the last two and a half years. When we started developing this, we had a complicator, actually a good complicator, but Desior was recently acquired by Paragon 28, that is an implant company out of Denver, and I'm sure you all know. So that put a little bit of a stop when they merged. We had to stop a lot of what we were doing. So now there's another player that is Paragon. But we're pretty advanced on the amount of data that we already have with the cadaver study, plus all the surgical patients. We recently combined the data set from my own data set with the HSS data set to feed the software with pre-op and post-op data. So we're very excited that we can very soon, hopefully in the next 6 months or a year maximum, we'll be able to have a predictive software surgical planning tool that will at least give you an idea. It will never be 100%, as you know, but it at least can give you an idea of a combination. So let's say you are a lateral column lengthening surgeon. You like to do it. You have good results. You want to keep doing. What we want to do is that potentially the software will be able to say, if you want to bring this to a neutral alignment, you need either like a 10 millimeter or 1 centimeter MDCO plus a 6 millimeter lateral column lengthening plus a 6 millimeter cotton. Or if you don't want to do a lateral column lengthening, you can do a 12 millimeter MDCO plus a Lapidus with plantar flexion, and then you can avoid the LCL. Or if you don't like to do a Lapidus, you can do an 8 millimeter LCL and a 10 millimeter. So playing with the numbers, getting to the same type of correction, right? So that's our aim. And I can share with you that unfortunately there's no time to present today, but we're also very excited with the prospective data that we have that will be submitted soon, where we found that in a prospective cohort of patients treated prospectively, when we improved peritalar subluxation, or when we improved subtalar joint coverage, that was the most important influencer or most correlated factor with the improvement in the patient-reported outcomes. And it's a concept that we use for other joints, right? I think you do some hip and knees, maybe. I don't know if you still do, but you do some sports. but there's some concepts in, for example, hip, where you improve coverage, you improve outcomes, like the people there. They have been doing this periacetabular osteotomies for hip impingement and things like that. But this is a concept that in foot and ankle we pretty much ignore. Like articular coverage is pretty much ignored in foot and ankle, and I think it's an easy concept, right? You get better. Joints don't like to be subluxed. They don't like it. They go into degeneration. So if we can predict that, and we can show that improves patient-reported outcomes, that improves patient outcomes, I think it will be a game changer for patient treatment. That's what I hope, at least.
Yeah, I totally agree, and I think that the weight-bearing CT scan technology is what will open that up, and I think it'll do so for the knee and the hip as well, for reasons you've mentioned. I want to open it up to the group. And Cesar, as I told you in email, this is a broad group. So we have physical therapists, athletic trainers, sports medicine docs, podiatrists, obviously orthopedists, and some researchers. So I'll open it up to the group on questions for Dr. Netto.
Hey, can you hear me?
Yep, go ahead, Bo.
Yes.
Hey, Dr. Netto. My name is Bo. I'm one of the foot and ankle surgery fellows here this year. Awesome talk. I've heard this a similar version once before at the Paragon course, and I could watch it probably 10 more times and still not catch everything. You know, with this new technology, with kind of all that you have learned and kind of contributed to the understanding of flat foot in the last 3 years with weight bearing CT, when you look at your surgical algorithm, what do you think is like the biggest one thing that has changed in your surgical approach? I know you said you like to avoid fusions, you really don't like fusing joints. So in a joint preservation kind of approach, what is the thing you're doing differently now most of the time that you maybe weren't doing a couple of years ago?
Well, excellent question, and happy, great to interact with you again. So I think when I finished my fellowships, Bo, I was very amazed by the amount of correction. I come from in Brazil. My mentor would pretty much fuse. There was always a reason for fusing the subtalar joint. I felt, it's too obese. Let's fuse the subtalar joint. Deformity is too bad. Let's fuse the subtalar joint. A lot of the patients were, they have pain of sinus-tarsi. This is arthritis we know it's not. It's extra-articular. Let's fuse the subtalar joint. So I came from a school where fusion of the subtalar joint was, for flatfoot, was almost, I would say, not 100%, but very frequent, right? And then I trained here, and I had my mentors would not do that much subtalar joint fusions. Of course, there's always discussions and preferences, but even at HSS, Dr. DeLand tries to preserve the subtalar joint as much as possible. Dr. Ellis is more pragmatic, and he fuses more frequently than Dr. DeLand. But I like the pushing the limits thing, right? I don't think fusions are as benign, even the subtalar joint. I don't think they're as benign as I saw the case that you guys were showing the ankle fusion before with the bad subtalar joint arthritis. So I was kind of, I think I was designed to try to save the joint and push the limits for the reconstructions. Yes, I will get burned because some patients it's too far gone, or it's a multifactorial environment where I will do flat foot reconstruction, and they're going to come back 2-3 years later and they will need a subtalar joint fusion. That will happen for sure, but I'm trying to push it. One thing, answering your question, that I've changed a lot is I don't like lateral column lengthenings. I was taught to do it. All my mentors pretty much do it, but I think it's not a very benign procedure, as we know from the literature, with lateral column overload and lateral foot pain. And I think you're creating all procedures create deformity, right? Because you're not really treating the parietal subluxation in a way where you're just correcting the position between bones. You always create deformity, even with a medial displacement calcaneal osteotomy. However, when you do a medial displacement calcaneal osteotomy, you're not changing alignment of joints itself. You're not changing alignment of articular facets. when you do a lateral column lengthening, you are putting a lot of stress in the subtalar joint. So as you distract, you're creating divergence between the facets in the posterior and anterior medial facet of the subtalar joint. So I don't like the procedure. So I have been trying to push more on the other procedures and to do less lateral column lengthening. It's been almost a year that I don't do a lateral column lengthening, and still to be proven, but I have been doing much more Lapiduses. So I found out that pushing the limits with the first ray, bringing the first ray down, and probably distracting the first ray, where when you distract the first ray, you increase the tension of the plantar soft tissue structures, is very, very powerful. So I have been doing this more and more Lapidus, even though we're talking about not fusing joint and Lapidus, you're still fusing a joint, completely different, not an essential motion joint like the subtalar joint, right? It should be a stable joint anyways, have some motion, but not a lot of motion. When you bring the first ray down, it's a tripod. We always talk about the tripod for cable varus, like you have a forefoot driven hindfoot varus, right? You put your first ray down, you derotate the deformity. But for flat foot is the same. If you bring your first ray down, automatically your subtalar joint will reduce from the paratalar subluxation or for the eversion. So I've been doing aggressive plantar flexion of the first ray with good MDCOs, close to 1 centimeter always, plus augmentation of soft tissue. I don't trust the soft tissue in isolation, if that could be your question at some point, like spring ligament reconstruction in isolation, but I've been augmenting the spring and the superficial delta more and more frequently. And I've been avoiding the lateral column lengthening, and my results are being super good. And I'll be publishing, we just published one initial short-term results, but long-term, I think that might be an option if you don't like to do lateral column lengthenings like I don't like to. Not sure if I answered your question. Maybe I gave you more questions than answers.
No, that was awesome. Thank you. That's kind of what I was looking for.
Well, I'm curious. So it's very interesting, Cesar. So I'm a lateral column lengthener, and like you, I that's how I learned it, and have had good results with it. But I'm compelled, and obviously you have a biomechanical understanding now with your work that is really valuable part of the conversation. So I'm curious. So like you mentioned that that by plantar flexing the first ray, you're increasing tension on the plantar soft tissues. But did I hear that correctly?
Oh no. The plantar flexion part is not. You're creating this with the plantar flexion. You're creating the tripod effect, right? The forefoot driven hindfoot varus. But when you put a wedge,
so you're creating stability.
You're distracting, even if you do with a cotton. When you put a wedge there, when you distract the first ray, then you're creating tension in the soft tissues. So it's a combination of plantar flexion and distraction. That's what I think it's the.
Well, and stability, right? Because by fusing the joint, you're now, there's not going to be sort of dorsal subluxation.
Yes,
at least at that
100%.
joint. Yeah.
The three things together.
Yeah, very good. Well, Cesar, thank you so much for doing this morning. That was incredibly informative, and we appreciate the discussion. This will be available online. So if you have learners, I've passed this along to our radiology colleagues. Unfortunately, they had a conflicting meeting, so they couldn't be here. But this will be available online. So if you want to point your learners to it, as we certainly will. Yeah, this will be valuable. So,
yeah, and I apologize I wasn't able to get to Alex Valgus and Cindy Moses. I'm happy to come back another day when you guys need to talk about the other ones. But it's a lot to cover, and I wanted to at least pass some concepts to the residents and the other healthcare providers.
That was perfect, and we'll definitely have you back to go through those other topics as well. So thank you, Cesar. Really appreciate it. Have a great Monday.
You guys too. Thank you so much.